Good morning, everyone. Hope everyone's doing well today on this gorgeous Tuesday. So thanks for coming to Grand Rounds. We're fortunate to have Dr. Fuster with us today, and I will turn it over to Dr. Berkins to introduce Dr. Fuster.
Good morning, everyone. We are very lucky today to be joined by the esteemed Dr. Valentin Fuster, Director of the Mount Sinai Heart, Physician-in-Chief of the Mount Sinai Hospital, and General Director of the National Center for Cardiovascular Research in Madrid. After studying medicine at the University of Barcelona, Valentin Fuster continued his studies in the United States. He was initially professor of medicine and cardiovascular disease at the Mayo Medical School in Minnesota, and thereafter in 1982 here at Mount Sinai. Then, from 1991 to 1994, he was the Mallinckrodt Professor of Medicine at Harvard Medical School and Chief of Cardiology at the Massachusetts General Hospital in Boston. In 1994, however, he returned here to Mount Sinai, where he was named Director of the Cardiovascular Institute, a post he has combined since 2012 with that of Physician-in-Chief of the hospital. Dr. Fuster has held innumerable positions that are very laudable, including President of the American Heart Association, President of the World Heart Federation, and is a member of the U.S. National Academy of Medicine, where he has chaired multiple committees focused on cardiovascular global health. He has furthermore previously served as editor-in-chief of the journal Nature Reviews Cardiology and currently serves as editor-in-chief at the Journal of American College of Cardiology, the ACC's flagship publication and a main American source of clinical information on cardiovascular medicine. His research is unparalleled in areas relating to causes, prevention, and treatment of cardiovascular disease globally, and spans the full range from basic science and molecular biology through clinical studies and large-scale multinational trials to population sciences and global medicine. His scientific contribution worldwide can be summarized by his H-index of 215, and he is currently the most highly cited Spanish research scientist of all times. Amongst his achievements, Dr. Fuster is the only cardiologist to have received the highest awards for research from all four leading cardiovascular organizations globally. And this year, the American College of Cardiology instituted the Valentin Fuster Award in Science and Innovation, which will be awarded for the next 15 years. In addition, in May of 2014, King Juan Carlos I of Spain granted Dr. Fuster with the title of Marquis for his outstanding and unceasing research efforts and his educational outreach work. It is a true honor to have Dr. Fuster with us today. Thank you so much for joining us.
Well, thank you very much for this opportunity and presentation. Thank you, David, and thank you, Franz. Obviously, I feel very proud to be the speaker this morning in Grand Rounds in Medicine. And I'm going to be talking about the present and the future. And I have to go back about 10 years ago when I decided to move from research in disease to research in health. We knew more about cardiovascular disease that we knew less about what makes us to be healthy. So the title of my presentation is Development and Innovation in Cardiovascular Health, which is an issue that is quite different depending on the age of the individuals that we are talking about, and always using new and advanced technology. I will focus today on imaging and genomics in terms of cardiovascular health, and I will focus even further to present fascinating new concepts that have evolved between 2020 and 2022. This is an important slide because it shows in the bottom what we mean by atherosclerotic disease. The disease is already advanced. What we are doing at the present time is we actually move from the bottom to the top, and that is what makes this artery healthy and how the disease begins. The next question is, are the challenges the same in terms of health and progression to disease in somebody between birth and age 20, between age 20 and 60, or even between 60 and 100? Well, this is in the right side of the slide, is very, very important. We are not talking about health in general and charitable work. We are really talking about the use of new technology to really address health. Imagenomics for example, artificial intelligence. Then we have single cell multiomics, where they provide macrophages that circulate, provide a lot of information about us, and actually new innovative therapies, approaches, which is, if we know what is making health possible, what are the biochemical and actually pathways of defense, can we enhance them therapeutically? This is a new approach, which actually we will be talking also today. So let me now begin with the first challenge, which is actually between age 20 and 60. Those of you that are listening between age 20 and 60, I will tell you that from the cardiovascular point of view, the main challenge is, do I have disease or I don't? Do I have atherosclerotic disease or I don't? You know, atherosclerotic disease, which is the #1 killer, unfortunately silent. So here's the question: can we know if I am developing the disease? Let's go back to something that you know well. The risk factors for cardiovascular disease basically are 7. 2 are actually physical, obesity and high blood pressure. 2 are chemical, let's say high cholesterol and diabetes. And 3 actually are behavioral: smoking, lack of exercise, and a poor diet. The concept classically has been that most of these risk factors affect the endothelium of the arteries, and then with endothelial damage, cholesterol enters into the artery, and that's how the beginning of the atherosclerotic process takes place. Well, to address health and how the disease develops, we have a lot of good technologies today, actually, that are invasive. OCT is one that we have been very involved for years, and that is, you put a catheter and you can visualize the lesions and the type of lesions of the arteries. But we are not interested on this at this time. We are interested is, can we have something that is feasible and can go to populations at need, for example, not just populations that are high economy and so forth. We are talking about the use of imaging that can be used globally. We have been working on this over the last 10 years, and actually we developed a type of technology that will be available for the public probably in the next couple of years. And this is 3D ultrasound. 3D ultrasound can image actually 5 segments of the arterial system: the 2 carotid arteries, the main aorta, and the 2 iliofemoral arteries. And then we use also a calcification of the coronary arteries to tell us something, let's say, indirect about the amount or the burden of coronary artery disease. So we undertook this project about 10 years ago, and actually we started with 4,000 people between age 40 and age 55. And the question is, who has disease and who doesn't? For example, here you have a cross-section of an artery. The disease is beginning. Subclinical disease, this is what we are talking about. And this is longitudinally. And then about 3 years later, you see the progression here in the cross-section and in the longitudinal. This all has been validated and actually published. Now I have to say to you very briefly what we have learned thus far. The first thing we have learned, interestingly, the atherosclerotic process begins in the iliofemoral region in about 75% of people. What happens is there is no manifestation because the arteries are big. This is why the first manifestation may be the coronary arteries because they are small. But really the disease in the large majority of people begins in the iliofemoral region. Now we have other things here. Let's go back to the 4,000 people age 40 to age 55. In fact, these are people who work on a bank, the Bank of Santander in Madrid. And this we have now, this is called the PESA study. And here on the left, you have males without any cardiovascular disease manifestation before until age of 54. And here are females. And these colors means The light color is one of the 6 regions being involved. Here is 2 to 3, 4, 5, or 6. And the results are really very dramatic. And that is males under age of 50, 2/3 have already subclinical disease in one of the 6 regions that I am mentioning. And in women, half of them. The disease accelerates later on in women after age of 50. But this is very important data telling us there is a high incidence of subclinical disease that already starts at early age. But there is more. And we just published this a couple of years ago. We are following these people for 20 years, every 3 years. At 3 years of follow-up, 41% of these people have already one or several plaques that have progressed. So the disease starts early in life and actually progress from the very beginning. Now, what is fascinating here is that in 900 of these people, we actually use completely new technology, and that is positron emission tomography to address inflammation and cholesterol deposition in the large arteries on the right. And here's magnetic resonance imaging to address fibrosis on the left. I can say to you from the beginning, it appears to be a progression between this inflammatory process of fatty streaks with cholesterol into the left, which is actually a fibrotic lesion, the lesion being stabilized. But now comes a critical concept that is quite new. It's the bone marrow. What is happening is at the moment that the risk factors lead to the deposition of cholesterol in the artery, this is a foreign body. And the foreign body calls for the bone marrow to react. And the bone marrow sends macrophages or monocytes to the site of the position of cholesterol. And now we have what we call is a war. And the question is, who is the winner? The cholesterol or the macrophages that try to absorb the cholesterol and to release it out of the body? Well, most of the time, the early process, which we call here actually is the defense mechanisms, are in favor, number one, of the fibrotic phenomena. So what I'm really saying that most of the people, if their risk factors stabilize or are modified, their war is actually won by the macrophages. And then what we have is this transition from here to the left, which is a fibrotic lesion. This is very nice to say, but the large part of population continue to have the same risk factors. And here comes the problem. The problem is that cholesterol keeps depositing, and the macrophages decide that they cannot do the job and they commit suicide, very well known biologically as an apoptotic phenomena. And this is here in red. Red means bad news, green means good news, and yellow means we don't know yet. Well, here's the story. When we talk about acute coronary syndromes, what we are now learning with all this technology, that the risk factors keep accumulating cholesterol in the artery, and finally the macrophages with the apoptotic phenomena release cytokines, release metalloproteinases that make the plaque very unstable, and most importantly, they release tissue factor, which make the plaque, if it ruptures by the metalloproteinases, to lead to a blood clot. So here you have a panorama that is fascinating, and that is a defense mechanism tends to win the battle if the risk factor profile is being taken care of. But it loses the battle if the risk factors profile continues and the cholesterol is the winner at the very end. The plaque becomes destabilized and the macrophages in an apoptotic phenomena lead to trouble. This is actually very interesting biological phenomena, and that is whenever we have a foreign body, the bone marrow reacts. COVID-19 is exactly what I'm talking about. COVID-19, this is a foreign virus, of course. The bone marrow reacts, and if the macrophages don't win the battle because the density of virus and activity of the virus is significant, these macrophages die, and they release cytokines, and there's a huge syndrome and the patients have to enter into the intensive units because the whole system is destabilized, including the vascular system. The importance of the bone marrow as a very critical defense mechanism into the processes that I am describing. Well, we published this 3 weeks ago, and this is the data on positron emission tomography in the bone marrow. Actually, what you see in blue is the bone marrow is reacting, and now what we see in the slide is the what I am describing, and that is with positron emission tomography, and that is the interaction of the macrophages with actually the cholesterol. And actually, we have all this data also proved in animal models and also in humans at autopsy. Well, this leads to this first concept that is cardiovascular disease begins early in life, unfortunately is silent. In most of the people begins in the iliofemoral region, which is now where we are putting the device to know of a disease that is going to be systemic. And we put it there to start with. And actually in countries with low economy, we are doing this at this time. And the risk factors and inflammation are the real protagonists of what is actually happening at these early stages. Well, now comes into number 2, very fascinating. We see patients today that they have one or none of the risk factors I mentioned. And the question is why they develop acute coronary syndromes and progression of atherosclerotic disease. And we have very fascinating data on this. Again, in the 4,000 people that I mentioned. Here we divided these people at high risk, middle risk, or moderate risk, and low risk, according to the number of the 7 risk factors being present. And in colors, you have the disease in the arteries. Well, fascinating. Look here in the left. People at low risk, 50% have already subclinical disease when only 1 risk factors or none of the 7 risk factors I mentioned. So what is happening? And this is what is happening. This is very interesting. Here we have, from the 4,000 people, we measure LDL cholesterol levels. In the normal population, according to guidelines, a normal LDL cholesterol is between 100 and 120. Fantastic, sure. This is guidelines all derived from people over age of 40 and with actually coronary events. But look, we measure something else, which is not in the guidelines, and is subclinical disease with this technology of imaging. And look what happened. For us, a normal LDL cholesterol with no subclinical disease should be less than 70 milligrams DL in apparently normal people. So this is very fascinating because we found the same thing with diabetes. We say hemoglobin A1C, between 5.7 and 6, we call this an alarm system. We call this pre-diabetic. Well, you can call it pre-diabetic, but we found the same thing. And this is already published last year. In the pre-diabetic population, we already see a lot of subclinical disease when we have already adjusted all the other risk factors. The same we are finding for triglycerides. So here is the issue. What we call normal today on guidelines is a completely primitive concept. It's abnormal because up until now, there was no imaging technology addressing how the disease begins from a healthy artery. And this is what I am presenting to you today. But there is a second issue, even more important, and that is what happens between age birth and age 40. Guidelines don't care. The guidelines start at age 40. Before age 40, what the guideline says, please take care of the risk factors. This is all what we have. Well, we went into the cardiac study, a fantastic study that began actually a number of years ago in people between 18 years and 30 years of age. And these people have been followed for 40 years. And now there are events in these people. So what we decided to do is to look at what about the cholesterol, LDL, hypertension, diabetes at these particular early stages. How did we do it? Very simple. We have all the measurements. And this is like an area. In the abscissa is actually the concentration that you have of LDL, of hemoglobin A1C and so forth. And in the ordinate, you have the timing of, in the abscissa, you have the timing, and in the ordinate, you have actually the amount. So you have an area over a period of few years, maybe 20 years. Larger is the area, more is the trouble. This was the hypothesis. Well, the hypothesis was a reality. Look what we found. Larger was the area on LDL between age 20 and age 40. Higher was the number of events in the long-term follow-up in the cardiac study. And when the area was very small, no events. So what we are really saying to you is that there's another problem here. And nobody measures what goes on between birth and age 40. So we disregard that completely. So this leads to a concept that is outlined here, which is, I think, quite important. Cardiovascular disease without obvious risk factors, we have two aspects that we have to pay attention with. What we consider normal is abnormal. So you may say there are no risk factors. There are, if you really look at subclinical disease. And second, nobody look at the cumulative, the accumulation of risk factors with age. This has not been considered. So now I'm beginning to understand why we see a significant number of patients that we superficially say there are no risk factors, so there's only one risk factor. In fact, we didn't consider that these people have abnormal risk factors in terms of levels. And we didn't consider what went on between birth and age 40. This is very critical. Well, we continue, and this led to the first randomized study in young people that we are developing at this time. And this is the PRECAD study. And that is people between age 20 and 40, we draw the blood, and if the LDL cholesterol is more than 70, we consider this is abnormal. And now these people now randomized into a very active treatment, bringing LDL levels close to 50, versus a control group treating the risk factors as it is in the guidelines. This is a 5 to 10 year follow-up of these young people, and the primary endpoint is imaging technology, how the disease progresses. And some of you may say progression of the disease doesn't mean events, maybe means something else. And these people are young, so we have secondary endpoint, the incidence of cardiovascular events, but are too young to have this objective to be fulfilled. But indirectly we can. How? This is a study actually that is fascinating and is going to be published very, very soon. And this is the bioimage study. We did the same technology in 6,000 people between age 60 and 100. In these people, there were events. And what we found is that the burden of disease at time zero, when we project the amount of atherosclerotic disease subclinical, we project to 12 years now, we have the follow-up, this is the number of events. So what we are finding is that subclinical disease, even at age 60, is one of the main actually prognostic factors that will tell what will happen at later age. And statistically, we are going to apply this format to the younger people when they have the same burden of disease than these older people at that age 60. So the concept is that for the first time, we have actually the first trial in young people, in this case addressing LDL cholesterol of what we consider is an abnormal LDL, more than 70 milligrams DL, according to the imaging technology that I presented. Now the question is, all of this is fine, but you tomorrow are going to see patients, and what did you learn about the patient that you are going to see from now on? Well, obviously, we have done actually 5 studies already addressing this issue. The concept is the following. If you present people that they have disease subclinically, they might change the lifestyle. Well, we address this in 2 ways. First, individually, and this is actually the model was actually in Kenya, In Kenya, in the poor part of Kenya that we work with, they have high blood pressure because they keep the food with salt. There are no freezers, and they develop hypertension. So they keep the food with very salty. And this is the problem then. What do? You go to these people and you work with them individually. By the way, these are the investigators. These are not the patients with high blood pressure. And we go to them and we do everything. We tell them what is happening and disease, subclinical disease. They put them in contact with nurses. Everything works perfectly. Results, fantastic, but expenses, very expensive. To approach today health at the individual base is very nice to do in your office, but you have 90% of people in the streets that they don't go to your office. And if you want to approach them individually, you can have success, but the expenses are tremendous. We learned this first. Then we took a second approach, which is group therapy. And we did this in the island of Grenada, in a town in Spain called Cardona, where my wife was born, and in 7 villages in Spain, which are here. And basically, you put groups of 10, you are obese, I smoke, I will help you, you will help me, and they meet every month. Well, the results are already published. Fantastic. Actually, the results are as good as the individual approach, but much cheaper, tremendously cheaper. And now I'm putting all these results together in a simple slide to portray the concept. And the concept is very interesting. Look what happened. Whether you go individually or you go as a group, this is improvement in health. And I don't have to go into the details now. This is already published. Or is going to be published, I'm sorry, this particular one. But look what happened after one year or two. Begins to drop. So the problem is sustainability. We can be very, very good, whether it's individually or with group therapy. But something goes wrong when we stop intervening, and that's what happened. But there's something more interesting even. This is the control group. And now we are learning about the culture. So when you do these individuals that work with these others, the control group begins to treat itself and is a control group. We don't do this intervention. So what we are learning here is the huge importance of culture. And that is the environment where you are. If it is an environment that deals with health, you can actually get into that train that is moving and in a very favorable way. So actually the concept here is that cardiovascular risk factors can be modified. Unfortunately, with us as humans, this tends to be transient. And now we are beginning to have data, which is fascinating. The reintervention is geometrically of more benefit than just single intervention. And that is, we need sustainability, but this doesn't mean that the reinterventions will be transient. In fact, are less transient and appear to be much more of benefit in an exponential manner. Well, this is all about risk factors, but we didn't say anything about genetics. And obviously, in these 4,000 people, and also in the bioimage study, we are doing very deep genetic data. We are obtaining very interesting genetic data. And let me summarize it for you. First, we were joined by 3 groups, the ARIC group in the United States, the group in Malmö in Sweden, and the women's health study. And this is the bioimage. I want to emphasize here. These are the 6,000 people that we studied with imaging between age 60 and age 100. And we pull all these individuals together in this particular study. And actually, it's interesting because what we did is to pick up 50 genetic abnormalities in the literature that may lead to coronary artery disease and cardiovascular disease, and we established a risk profile by the number of mutations in these 50 genes, high risk, middle risk, and low risk. And certainly was a relation with progression in disease and events as in the vertical axis. But we did the same with the risk factors. We get the 7 risk factors and we establish high, middle, or low risk, depending on the risk factors available. Fascinating, the same thing. But now the three aspects that we learned perhaps were actually not predictable. First, no relationship between genetics and the risk factors I mentioned, except in diabetes type 1 and in familial hypercholesterolemia. Sure, genetics plays a role in the tobacco reacts to the hypertension and so forth, but the way that we did it with the technology used in 2016, that's the data. However, most of the people who are at high risk genetically, they also have 1 or 2 or 3 risk factors. And when we look at hypercholesterolemia and we treated these people, actually we reduced the progression of disease and actually events by 50%. So there is no excuse by saying this is a genetic problem in my family, therefore I give up. Most of the Americans, 95% of them have one of the 7 risk factors I mentioned, adult people. So there is no excuse. We should try the risk factors. And this is actually very important. An aspect that perhaps I will mention is we easily talk about genetics in people with family history. My father had a heart attack at age 40. What we found in this study is that in a large majority of these people had nothing to do with genetics. The father was a smoker, as I am. And therefore, don't call genetics people who have disease under the age of 50 and the family have disease unless you go to the risk factors that are affecting the family, because that may be very much involved rather than the genes in itself. Well, this is what we learned, but there is something else that we learned, and it's the so-called chip. And you are all aware, particularly the hematologists, of what I'm talking about. And this is the story. I don't want to go into too much detail, but you know the chip means clonal hematopoiesis of indeterminate potential. Well, we have been studying actually all these cells coming from the bone marrow. We have been doing PET and so forth. And now we are learning something very fascinating. As you know, these are cells from the bone marrow that are actually have mutations. They are abnormal. So, and one of the genes that we actually studied is the so-called TET2, but many others. And basically, this is an issue that is quite important because maybe that the defense mechanism of the bone marrow may have mutations and actually the defense mechanism is not working. The motor engine is not working. Well, this is actually, we did the studies in humans and in the mice, and this has been published as you see in the bottom of the slide. And here is an example which is very interesting. The macrophages from the bone marrow, there are at least 6 types, but very succinctly, there are 2 types that are important, type 1 and type 2. Both are defense mechanisms. The type 2 is profibrotic. There's something in the artery, they try to take the cholesterol out, and you lead to a fibrotic phenomena, as we saw from PET to MRI. PET showing the cholesterol deposition and the inflammation, the MRI showing the fibrosis. This is very good. But here's another macrophage. This macrophage goes when there is trouble. There is a plaque that is rupturing. There's thrombus formation. There's a vulnerable plaque. They get in and they do the job. What they do is they clean the artery, but probably the cleaning is too much. Too much, and actually the color to this appears to be interleukin-1 of macrophages that circulate in blood. They recognize this, they release interleukin-1, and then they activate the other macrophages that are not circulating from the bone marrow, and now there is a destroying process here. A defense mechanisms, they go too far. But here's TT2. What TT2 that we are learning now, and again, we have good studies in humans and in animals, the TT2 prevents this to go too far. It's a defense mechanism. But when TT2 is affected, is mutated, there is no defense mechanism, and now we are learning as this genetic trait of a TT2 that is mutated is a significant risk for cardiovascular disease. But there is something else here. What about if interleukin-1 is so bad that makes this whole system to go beyond? What about if we actually neutralize interleukin-1? Well, This is what was done in the CANTOS study, a monoclonal antibody actually interfering with interleukin-1. And the results were so magnificent that the concept of inflammation being important in cardiovascular disease actually evolved very aggressively 4 years ago by the group in Boston, and actually a group that we are now collaborating with this whole issue of the monoclonal antibodies against interleukin-1 and the enhancement of TET2. And this leads, go back to the slide that I presented before about defense mechanisms. And that is, you have one defense mechanism. There's very little cholesterol, the macrophages win. Then if there's a lot of cholesterol entering there, the macrophages lose, and the apoptotic phenomena may lead to an acute coronary syndrome. And finally, we have CHEAP. That is, everything is fine, but the motor engine is not working. That is, the defense mechanism goes there. And this appears to be a critical risk factor of cardiovascular disease and atherosclerosis in the older ages. And I'm not talking about oncology or leukemia that may be derived from the CHEAP. But what I'm saying to you is we have 3 defense mechanisms that are now identified, and one works if we take care of our health. The other 2 may be troublesome, particularly if we don't take care of our health or if we have bad genetics. So, and this is actually the editorial comment of the paper that we wrote, that we presented 2 weeks ago, and that is the bone marrow may be the root of being a cardiovascular evil. What that means is that may be very good in the defense mechanism number 1, not good in 2 or 3. Well, and this is the concept in the bottom of the slide. That is a very interesting concept, and that is, sure, the macrophages may be very troublesome, even when they are, either when they become apoptotic or when they have gene mutations. Well, this is interesting, and for the challenge that we have between age 20 to 60, but what between age 60 to 100? And now, in the next 5 minutes, I just tell you fascinating data that we are obtaining at the present time with these particular people of the elder population. And here's the story. Here we'll have Alzheimer's, with about over 100 years ago, decided that his disease, it was a pathologist, was actually a disease of the small cerebral arteries of the brain. And whether it was arteriosclerosis or not, this is a question. Subsequently, and we are talking about Alzheimer's, here we have Alzheimer's disease with a good relationship between Alzheimer's progression and the risk factors that I just mentioned for large vessel disease. There's a relationship. In fact, there is established evidence. Well, when we saw all of this, we decided to begin to apply our imaging technology to the brain in all these people that I'm talking about that I have presented up until now, particularly people at middle and actually older ages. And I'm presenting to you the results, and we are publishing this at the present time. And this is very simple to follow. Number 1, the same risk factors that affect large vessel disease actually may affect the brain. And you are going to see actually how. This is just the large vessels. We all know this. And I presented this to you, how the 7 risk factors lead to a large vessel disease. But here's the brain. What we have found when we do MRI and we quantify flow in the brain, here is with colors, hypoperfusion, for example, in hypertensive people that have not been treated, or people with very high cholesterol or diabetes. This is what we see. Then what we see after is we look at positron emission tomography, and we just published this, and there is a decrease actually of uptake of glucose in the brain on people with risk factors who have actually a decreased flow in the brain. And finally, this leads to cognitive dysfunction. There are 4 aspects I presented here, but what about Alzheimer's? Well, we may say that perhaps this process is what Alzheimer's described, and that is, this may be a disease of the neurons, but it may be accelerated by a vascular component. But we found a vascular component, and I cannot go into the details at this time, but there is the tiny arteries in an animal model that we have, a mouse model of Alzheimer's. There are small clots, and we can prevent these clots by significant antithrombotic therapy, which is leading us to now move into a field of clinical trials in people who are at high risk of Alzheimer's. And I don't want to get into this. But look at, I have a number of question marks. This study is based in 300 actually individuals, 150 here in New York and 150 in Madrid. But what are the question marks? The study was cross-sectional, was not longitudinal, is not the same individual that we have followed from the beginning to the end. And this is the study that now we are funded to do longitudinally. And this is a fantastic study of 1,000 participants in which we do everything that we mentioned in terms of the technology that I mentioned, going into the brain, following these people for 20 years. And most importantly, we are now have biomarkers in the blood that we didn't have before, biomarkers of injury in the brain. This is like troponins of injury in the heart. This was not available before. And we have developed this with a fantastic group in Amsterdam that has made this field very prominent at the present time. And at the same time, we measure what tau, we measure amyloid pro-beta, which is we think is the one that causes small clots in the tiny arteries. So this is a project that we are now very involved at the present time. Well, this is all nice, very exciting, but we are missing something. This is all leading to disease. And the question is, what we are doing at young age? Are we doing anything? Well, we are beginning a trial. This is fine. But to me, the most important aspect of my presentation are the next 5 minutes. And I'm only going to give a summary of what we can do between birth and age 20. This is the critical issue to discuss. All started with Sesame Street. For some reason, I began to work with them. I don't remember exactly the details. I think they were interested into what I was doing with health and children and so forth. But I became part of the group. Sesame, as you know, is a television program of education in children between age 3 and age 6. Well, the first thing we did is to change Cookie Monster. Cookie Monster was eating cookies 7 days a week. We made it 1 day a week. Absolute success in children. The children began to think, what is all of this about? And they began to talk about health. Well, this has actually, interesting, has changed completely the philosophy of Sesame Street. Sesame Street is now in countries with poor economy, is dealing with HIV, is dealing with Chagas disease, is dealing with all the aspects that have to do with health and prevention. So this is how an educational program that at the beginning was generic with no clear objective now has a very clear objective. Well, this happened that then I took this tremendous opportunity to start working on children between age 3 and age 6. And here's the story. This is very important. The story is that children at this young age have very few centers in the brain. The neurologists know this. And whatever you tell a child is captured tremendously, is captured and then comes out when they are adults. Very well. Now remember yourself at those young ages, the tremendous influence that whatever you were told and saw have in your lives today. This is the concept. Because later on is a chaos. There are many centers, there are many messages, and we really do not store, because of the complexity, what we are hearing or what we are seeing. So we focus on young children. Well, now I'm going to provide you with the data. We started with 5,000 children in 3 different communities: Bogota, Madrid, and Harlem, New York, socioeconomically completely different. And these 5,000 children were randomized. Half of them, 60 hours over 6 months, how your body works, healthy food habits, physical activity, and how to control the emotions. So what we are doing with these children is we are teaching them to say no when they become adults and they are confronted with drugs, alcohol, smoking, and so forth. A randomized study. These are all published. I have to say to you now that this study, I wanted to do it in the United States, and I was completely neutralized by the boards of health, saying that this didn't enter into the whole objectives of education at that age. Well, as president of the American Heart, I got hold of Clinton, and Clinton told me, you know what? You will not make it in this country. You should go to Central America. They are very organized and passionate. And this is how I started in Bogota. Then we went to Spain, Madrid. And then when we published all of this, we were called from the United States to really move on. And we started in Harlem, and now we are starting in New York. So this is how life works. Well, these are the good news of the study. Very excellent. You see, we started here, great results. But now comes the problem, and this is number 2. What we found is sustainability. The first children we did in Bogota, about 5-7 years later, they lost a lot of what we told them. But if you reinstitute the intervention at later age, at age 10, it may be exponential, as we found in the adults. Well, this led us to this complex slide, which I'm not going to say a word, except we are dealing with 50,000 children around the world, all randomized, particularly in one stage of intervention, young age, others starting at age 10, others have been intervened at age 3 to 6, and they rarely intervene at age 10. We are going into age 15 and age 20. So what we are now doing is working in, we believe strongly that the best opportunity is at a very young age. But this has to be repeated, and we feel this will be exponentially positive. And this is actually, all these are randomized studies that are going on in children around the world. And we talked before about the culture. We said, no, these children have more influence on the parents in terms of health than the parents in the children. And actually, they go home and they tell the parents what to do, to eat dinner together, to actually exercise, to eat properly, and so forth. Then we saw the issue of the control groups. We said, now we have to develop something new, which is a cultural program that goes to the family. And this is actually a program that is starting next month, and is fascinating. What we do, the same objectives that we deal with the children, knowledge of how the body works, promote physical activity, healthy food habits, and encourage better management of emotions, we go to the whole family, grandparents, parents, and then children and grandchildren. And actually with the objectives, with the modules being a little bit different in terms of how we address these 4 issues at these different ages. Well, basically, the process is 1 year, the Family University of Health. You see, these are the 4 modules, it's 2 weeks each, and then we repeat them to the whole family up until a year. And at the end of the year, we give a diploma, which is Family University of Health diploma. And actually, you know, you may know I am a Muppet now in Sesame Street for all these studies, and he's a Muppet that is a doctor. Well, the sign is the doctor called Dr. Rooster. Well, anyway, this project is fascinating. And actually, the Muppet is now coming in the United States, has been now only in the Spanish-speaking countries. The issue is the culture, and it's the culture of the family. Well, we went further, and we developed now this project in New York. It's in the 5 boroughs of New York. We are now entering with intervening children in parts of each borough, socioeconomic high or socioeconomic low, and we are looking at the intervention, as I mentioned, 60 hours of the 60 months, and we look at cardiovascular health in terms of aptitude, habits, and knowledge, and then biological endpoints. We look at many factors that may contribute to the results: the environment, pollution, the family, the teachers, what motivates a teacher? And certainly we are moving into sustainability. So everything I presented to you now is now going to start in New York in the 5 boroughs. And we didn't finish this, and now we are randomizing 2 towns of 4,000 people. One I mentioned, Cardona, is where my wife was born in the north of Spain. And we are doing everything I presented to you today in the elderly, in the middle-aged, and in the children. This is one town, and is actually randomized with another town called Cheyenne, which is 20 miles south, are 2 mining towns in recession. The Cheyenne will serve as control, and we have a 5 to 10 year follow-up of all the interventions I mentioned to you to see if we can change the health of a town. Well, I summarize now in a single slide. What we are learning, dealing with 3 populations and trying to understand health with the best technology available, what we are learning is the following. Nothing new, actually. Older we start, higher is the cost, less is the benefit. And you know how tremendously expensive today is medicine because we are addressing medicine too late. In fact, we should go much earlier. Not only much earlier, I would say even in the mothers, even during pregnancy, even before pregnancy, but we are now beginning to get there. But we should start at least with children in young age. At that time, potential benefit is tremendous, I believe, and the cost is very little. So I just summarize with the same title I presented to you before, with something added. I presented to you 5 concepts in people between age 20 to age 60, remember, obtained by imaging. 5 concepts that we are obtaining at the elderly ages in terms of degenerative brain disease and Alzheimer, and the 5 concepts I presented in children that we are now evolving. So I finish by saying to you that I feel very excited about all of this, and so all the groups that are working with us on this, because we are addressing something that is completely forgotten, and that is we should prevent disease and trying to understand health, and then trying to enhance health, even the defense mechanisms that we are learning about. Anyway, thank you very much for this opportunity, and it's a pleasure to be with you today. And we will continue to provide information because it's all very new. Thank you.
Thank you, Dr. Fuster, for an excellent talk. So I invite questions or comments in the chat. There's a question by Dr. Chen. Thank you, Dr. Fuster. He says, you described the efficacy of IL-1 antagonist in high-risk patients, and also the idea that the bone marrow is contributing to an axis of inflammation in everybody. Do you believe there will be a role of anti-inflammatory drugs in prevention of CAD in patients who are not yet at high risk for recurrent MI?
I am not sure about that. The pathways of inflammation are very complex. And therefore, to go with drugs, anti-inflammatory drugs, which is a consequence of risk factors that we have ignored, to me is going backwards. I personally believe that we have been talking about risk factors for many years, but in a very superficial way. I think now what I am presenting to you is not to address the consequences, which is an inflammatory process, but try to address the root from the very beginning. So I'm not trying to answer your question in a negative way, but I think we have to go step by step in doing first the right things rather than thinking on drugs and otherwise, which is at the end of the pathway.
Dr. Kraft has put a message in there. Dr. Kraft is with us today, our new chair, everyone. Fantastic talk, tour de force. I may have missed this. Are you working with pediatricians to enhance screening programs and with the internists, family physicians to screen young adults? not sure how routinely awareness of early CAD and the importance of screening is known.
Well, the pediatric group at Mount Sinai learned of all of these, and I gave grand rounds, Monica, I gave grand rounds to pediatrics about 3 weeks ago. The results have been overwhelming. Now I have a number of pediatricians who are now coming to see me to see if they could begin to collaborate. Right. I think what has happened is this has been a field that I found very difficult to start in the United States. I have to tell you frankly. Right. The institution I have in Madrid is like NHLBI, and we have been able in Europe with funding by the European community to start. Now that we are back in the United States, I think it's going to be fantastic. And I think, frankly, it's the time to begin to talk with the pediatricians. I have a meeting today with Lisa, actually the head of pediatrics, to see how can we move now that we are starting the 5-borough project in New York. So I feel this is going to happen. And by the way, congratulations, Monica, and it's a pleasure to see you here.
Great. Thank you very much. Outstanding talk.
Dr. Fuster, I'm curious if you have begun discussions with the medical school or how you're thinking. Medical schools focus a lot on that pathophysiology. And so how you're thinking about incorporating your approach that comes from the concept of health into medical schools.
Well, actually, I have not, but there's something has happened. The students have heard me talking about this in different venues. And now what I'm having are students coming here, first year, second year, and they say, how can we start working with you? I frankly didn't approach the medical school for obvious reasons. This is a very dense program, and I go step by step because otherwise this can become very, very diffuse. But I will tell you, David, this is the time to really get into the medical school. I think this type of preventive and talking about health is critical in the medical school, rather than just beginning from the beginning talking about disease.
Yeah, absolutely. You make some excellent points, Dr. Fuster. It's really wonderful to see your progression of your thought process in all of this, and also to really have you at our institution and in our department. So thank you very much, Dr. Fuster, for your lecture today, and have a great day, everybody. See you all soon.